So we're going to kind of expand the lens. So far, we spent the whole day talking about MAS lung patients. And through a series of conversations earlier this summer, both with many of the doctors here and in our patient group, I started kind of recognizing maybe another phenotype which we see in our group on and off, which is these are also the other type of recurrent MAS patients with a different set of things happening and liver involvement. So I thought, as with our stated goal of finding the subgroups within SJIA, or at least within the refractory SJIA, we thought maybe this would be a second group that we start highlighting and bring to your attention. So with that, I'm going to introduce you to Zuli, okay, and to Katie. And maybe we start off with Zuli. You want to talk about your story in 3 to 4 minutes?
Yes. Sabrine, she was diagnosed, well, no, she started with the typical symptoms in 2017, November 2017, just rashes in her hands, palms. And after that, I took her, of course, to the hospital, and they just said it's just a simple virus. Well, months passed because she was getting the rashes off and on, but nothing else, no other symptoms, until like in January, February, she started developing fever. So that's when we got sent to the allergist, then to the infectious disease, and then after that, they saw her ferritin going up in the 900s. Then we got sent to the ER again. That's when everything started. She was there for a month and finally got diagnosed in May of 2018. She only had rashes, fever, just muscle pain. That was it. She started, of course, they did the steroids, IV steroids. It worked for a few days, but then she declined, started going up to the 10,000s, the ferritin. After that, that's when they introduced her to anakinra. And we left with that. Everything was well. Even the liver was perfect. I mean, it was normal. But then back in November, she started to decline once again. And when she started to decline, they noticed her liver was going up in the 100s, 200s, so they got concerned. So they increased the steroids, but then she started to decline more, and in February, she ended up going back into the hospital, and her ferritin was like 800 at that time. Her ferritin has always been okay, except when she was diagnosed. So they did IV steroids again, and we were there for like 5 days. The liver was like in the 200s. So we switched to Actemra. Actemra seemed to be okay, but it didn't do everything. She started to develop throat pain. They thought she had like some kind of sickness, so they found out that she was having like symptoms of an adult onset Still's disease patients, because they tried everything, and she's 5 years old, and she was just, her throat was shut. They couldn't figure out what it was until they put it together. So that was a new symptom that came in. Then itchiness started coming in. She never had itchy problems. So then we left with Actemra, but I still didn't feel comfortable. She was doing well. I called her rheumatologist 1 week on Actemra. They told me, give her the Kineret. So now she had 2 biologics in her, the Kineret and the Actemra. Like within 2 hours after I put Kineret, she was herself again. No throat pain. She was jumping, dancing, everything. Everything was like, got my daughter back. So then we were happy, but then we go back, like it was like a couple of days before her Actemra was due, and the rashes started to appear, and I was worried about, because I felt like in my heart that Actemra wasn't the medicine for her, but we went ahead and gave it to her, and she had an anaphylactic reaction. They checked her liver. Her liver jumped to like 400. In the 400s, they felt that it might have been a mistake. They checked it again. It was 500 within a day. So she got admitted. Then it started climbing from 500 to 900, then to 1,000. Her liver enzymes jumped almost to the 5,000s. Her LDH to the 8,000s. Now her They do check her IL-18 constantly. When the liver issue was happening, her liver issue, her IL-18 was 364,000. When it started going down, when just with IV steroids, of course, the IL-18 started to drop as well. Um, she started getting. It took months before she got okay, and her IL-18 was always high, till her liver started to go down like normal, like a few months ago. Her IL-18 was 35,000. So then we started having problems again 2 weeks ago. Rashes, fever. We checked her IL-18. It jumped within 2 months from 35,000 to 260,000. And her LDH jumped to almost 5,000 as well. Her ferritin went up like to around 600 or 700, which, like I said, her ferritin's always been like 300, 400. It's never been that high compared to that. So right now, that's where she is. We switched to Ilaris and IV steroids every week, then every 2 weeks. But now it looks like she's failing Ilaris, and we started her 2 weeks ago on IV steroids again, and that's where we're stuck. And her liver just, we checked it 2 weeks ago, and it jumped to 600. So it's going back up, even with the IV steroids. Oh, yes, I'm sorry. She did have a liver biopsy done, and of course, they thought maybe it was an echindra that did the damage. Some were saying yes, some were saying no. But then the echindra was out of her system for such a long time, there was no reason, and her liver enzymes just went down drastically with no change, and then they're starting to come back up again until we got it sent to Cincinnati, and they checked deeper. And they did say that there was signs of MAS inside the liver tissue. So right now we're in that thing again. I spoke to her doctor 2 days ago that if her liver enzymes keep increasing, they're worried that might be MAS again in the liver. Dr. Guzman reached out to you, but it's Dr. Ramirez, her doctor. So.
What the liver biopsy shows? The liver biopsy showed massive activation of Kupffer cells. There were lots of macrophages based on CD1, CD3 staining, massive infiltration of the liver with CD8 positive T cells, occasional CD4 positive T cells. I don't think we saw frank hemophagocytosis. I think it was just one cell there. But again, sort of massive activation of Kupffer cells, not just expansion, but they're very plump. And then lots and lots of CD8 positive T cells. And all the viral studies are negative. No, that's sort of, we actually got it by mistake, I think, this liver biopsy. It came with another liver biopsy, which is very similar. And it was just a few slides, so we were very limited in terms of what we could do with those.
And if I remember correctly, at the point that your child's biopsy was done, the ferritin was not very high, but the IL-18 was really high, correct?
Yes.
Yeah.
What you described, are you going to talk about the iPad?
Sure.
Oh,
No, I mean, if you want to bring it up.
okay, so this is not my work, but there is this entity called idiopathic pediatric acute liver failure, which is exactly like it sounds. I don't know what causes it. It's children. It's acute. It's liver failure. And so it's very hard to manage. It's thought to be due to immune activation in the liver. And when you look at the liver biopsies of these kids that have called IPALF, it looks a lot like what you're describing. And we've had a few of those in Pittsburgh, Philadelphia, and Chicago seem to be the places that are sort of spearheading this, and they're doing some special stains that show that the CD8 T cells are CD103 positive, and there's some other stuff that they've done there. We've measured IL-18 in a bunch of those, and they're not uniformly as high as the MAS patients. So it's, but right. So this could be. But this is not in the. This is not I. Right. It's not idiopathic.
This is
Right.
I'm going to ask what these patients were alluding to, are these in the context of
No, these are previously healthy kids who
just
just,
going to liver,
right.
acute liver failure?
So these kids do seem to have an SJA-like disease at the beginning.
And like my daughter, she's never had any arthritis since the beginning. They never diagnosed her. It's more, she's always been more systemic.
And the thought with his IPALF patients is that they have like a liver-only HLH type process, and that some of the therapies that we've been talking about today, with the exception of IL-18 blockade, are being talked about for those patients as well.
Did you do a genetic screening?
They did. They did the whole sequencing and what is it called? The genetic screening. Yes. And the whole panel. Yeah. Yes. Yes.
You want to move on to Katie?
Sure. So my daughter Ella, she's 2, and her story starts shortly after she was born, actually. When she was about 1 month old, she started dropping off her growth curve. At 4 months, they did a failure to thrive workup, and it revealed a little bit of AST elevation, a little bit of platelets were elevated, but at the time, in the context of a well-appearing kid, she was still developing normally. We kind of just didn't pay attention to it and went on and just thought she was slow to grow. And so then she first started having symptoms of SJA when she was almost 8 months, fever and rash. Initially admitted for atypical Kawasaki's, which seems to be a common theme. Didn't really respond to IVIG, had a normal echo. And at that time, we didn't have a pediatric rheumatologist where we were, but fortunately he was somewhat curbsiding a friend that he knew, and she was at Duke and suggested SJA. So we were transferred there, and we met with her that day, and she said, yes, that's what it is. Let's start anakinra tomorrow. Well, that night, then Ella spiked 3 back-to-back fevers, and they were like, well, this is not the normal pattern. So we left on a prednisone taper, and the thought was, if this is Kawasaki's, it will maybe be curative. If it's SJA, her symptoms will come back. And so that's what happened. We tapered. She also had 6 echoes, and they were all normal. So then we started the anakinra, and within 24 hours, she was like a whole new kid. And she also, within 2 months of being on anakinra, she went from 4th percentile on the growth curve up to 30. So looking back, our rheumatologist is suspicious that she was having inflammation pretty much since birth. So we did the anakinra over. This was last summer. Everything was going great. Everything went away. Her labs normalized. And then I think it was about 2 months afterwards, she got her second flare. We tried to increase the anakinra. We added steroids. Wasn't working. Then we struggled to get approval for canakinumab. And in the meantime, she went into her first MAS episode. It was fairly typical, resolved with I think only 1 dose of IV steroids. We went home, and then 10 days later, she went into a much more severe episode of MAS that ultimately was discovered, triggered by CMV. But that one was a little perplexing initially because at diagnosis and with her first MAS, her ferritin was 4,000, but this time her ferritin was only like 400, her CRP was less than 0.1, but then her liver enzymes were drastically elevated. Fibrinogen was dropping, platelets dropping, all of that. So they were kind of confused until they saw the CMV and they said, well, maybe that explains the liver. So she resolved from that. We switched to Tazi and did that 5 times, I think, and then she developed a anaphylactic-like reaction. So we took that off the table and tried to go back to canakinumab. This was last winter. We were still on steroids at this point from the MAS and was doing well. We weaned off completely the steroids, still doing really well. And then 2 weeks later, we checked her labs, and her LFTs were back up into the 400s and 500s. So at that point, they brought in hepatology. They were thinking possible drug injury, possibly the CMV, though she was seronegative at that point for her CMV, or possibly MAS. So we did a biopsy. And I'd say you could call it inconclusive. There's some disagreement of her results. So I'll quote it from the report. It was punched out lesions of hepatocellular necrosis is what they saw. And hepatology felt this was MAS related, but rheumatology said we've never seen that in MAS. We think maybe it was damage from the CMV. She did not have any active CMV in the liver. So that's where we were with that. And at that point, let's see, we were still on the canakinumab. We went back on steroids, and things were kind of going well. And then we had the repeat where her liver enzymes started to go up again. And generally, this is accompanied by illness. She gets, usually her first signs of a flare would be fever and splenomegaly. So then we decided we need to try something else. For about a month, we added anakinra to the canakinumab, which was really actually from mine and my husband's urging, just because she had such a wonderful response to the anakinra. And it did seem to improve, but then symptoms started to come back. So the beginning of the summer is when we dropped the anakinra, continued the canakinumab, and added tacrolimus. And that seemed to be her miracle drug for the first time in her life. Her labs were completely normal. That was probably a month ago. And then we started to see return of symptoms. Her LFTs were starting to go up again. Now we're at a trough of 6.4, which I think for her is kind of upper limit of normal, being 2. But she's starting this week, her fevers and her spleen is big again. So that's where we are. Anybody have insight on her liver biopsy?
I think they're going to talk about. If no,
Dr. Balvick at Duke.
Very early start of systemic in inside, maybe at the age of 1 or 2 months.
Yeah, I mean, you know, she doesn't have symptoms then, but they saw the inflammation and the growth curve drop. So that's just kind of a theory.
I'm sure that they did genetics as well.
Yes, no, it was all negative. With Ella, the only time her liver's really been palpable is when she had the MAS and the CMV. Since then, it's not palpable and not seen any enlargement on imaging.
I'm just curious if any functional studies were done. Like I know we are talking about monogenic HLH genetics, but if the CD107A or NK function or anything in terms of functionally, because many of the patients with primary HLH, if you do biologicals like anakinra or tocilizumab, it sort of blocks certain inflammatory pathways, but the liver will worsen. So I'm just curious in some of this very early onset refractory patients. I know there are, I think Dr. Grum has reported variants in perforin and other pathways. So it may not be a real biallelic mutation, but if there are variants in a primary HLH pathway, and we are doing only a single pathway blockage, these patients might have other organ manifestations. And the way to pick up might be like, instead of just doing genetics, CD107A will pick up overall the entire pathway being intact or not, and perforin granzyme will pick up.
Similar patient who actually is in a emapalumab medical trial right now. We did all those functional studies that came back clean.
Got it.
So, but in general, SGIA, MAS patients tend to have a little higher, no, let's
Yeah,
see.
yeah, but talk about functional studies.
Yes,
So
functional they all.
functionally, we could not pick up anything in that particular patient. So these other patients we're still looking at.
But there are mutation negative HLH patients, primary HLH patients, which show functional